Hi, ladies and gentlemen. My name is Dr. Frank Bonura. I am a gynecologist, and the slides don't go. I'm a gynecologist. I'm director of the osteoporosis program here at St. Catherine of Siena. And I was on the speaker bureau for most of the drugs for osteoporosis.
I'm having a little difficult. Oh, there you go. All right, there you go.
Our topic today is osteoporosis. Osteoporosis is not a disease of women. It's a disease of men and women. It's a chronic disease. It affects all your bones. There's a decrease in bone strength in your bones. They fracture easily, and it's a disease that we can prevent, we can diagnose, and we can treat, but we cannot cure everyone that has osteoporosis with the drugs that we have. Now, the first slide that you see is your skeleton. Our skeleton protects our internal organs, the heart, the lungs, the liver. It also ligaments and muscles attached so we can move around. It also is our supply of calcium for our body, and in our bone marrow, we make our blood cells. Our bones are living tissue. They're not dead tissue, and they're composed of a protein that makes the bones flexible. They're composed of crystals of calcium and phosphorus that make the bones hard, and there are specific bone cells. The bone cells are cells that break down the bone when there's a micro crack. There are cells that fill the micro crack, and there are cells that tell these other cells where to go. Now, normally what happens in our life is that we build bone, and the cells that build bone are called the osteoblasts. So from childhood to about age 30, women and men arrive at our peak bone mass. That's the maximum amount of minerals in our bones. And then in our adult life, between around age 30 to around age 48 in women, and men to about 30 to about 50, there's a balance between bone breakdown and bone formation. And what happens during this time, every year we replace 10% of the mineral content in our bone. And this slide shows that from a young age, the ladies are the yellow line, the gentlemen are the blue line. Between age 20 to 30 to about age 48 in women, 50 in men, there is a balance. Bone breakdown equals bone buildup. But in women, and this slide shows it, it shows the cells that make the micropit when we have a break in our bone. They make a little pit, they secrete an acid and enzyme, and that micropit then is filled. But there is a balance between bone breakdown and bone buildup. But what happens in women, the few years before your menopause, at around 47, 48, with a decrease in the amount of estrogen that you're making, your ovaries have a decrease in the production of estrogen, which protects your bones, you start to lose bone. And you can lose 2 to 5%. The few years before menopause that we call the perimenopause, and 2 to 5% the first 5 to 10 years of menopause when you stop menstruating for a year. And what happens is the cells that make the micropits, but the cells that fill them don't work. And what can develop is you can develop cracks in your bones. So here now we have a picture and a definition of what osteoporosis is. On the left is normal bone. You can see in normal bone, there are cross strips that are attached. and there are no large holes. On the right is an osteoporotic bone. You can see that the cross struts in the bone are very thin. Some of them are broken. And what happens is, the definition is, osteoporosis is a chronic generalized bone disease in which there is a decrease in the mineral content in your bone, a change in the microarchitecture, those cross struts. And what happens is there's a decrease in bone strength, and any bump or fall causes the bone to break. Now, 10 million of ladies and gentlemen in America have osteoporosis. 8 million are women, 2 million are men, and 44 million of you ladies and gentlemen have osteopenia. Last year, this is an old slide. Last year in America, there were 2 million fractures, of which 300,000 were hip fractures and 700,000 were vertebral fractures. In women, there are more osteoporotic fractures in women than stroke, heart attack, or breast cancer. If you've ever had an osteoporotic fracture, within a year, 10 to 20% of you will have another fracture. So that's a big risk factor for fractures. These fractures lead to 500,000 hospitalizations and 180,000 admissions to nursing homes. Here again are pictures of normal bone on the left, normal cross struts all attached, and on the right and on the bottom of osteoporosis, you can see that the outer part of the bone is thinner, the shell of the bone is thinner, and inside the bone you see breaks in the cross struts, and you see these large holes. To make it an analogy, this is a book bench. This is a book bench that has good cross struts. Look how many books it can hold. As the cross struts get thinner, we hold less and less books. And at the end, when they're broken cross struts, what'll happen is the books will fall. Now, there are two types of osteoporosis. The one type is primary osteoporosis. That's because of your age, you're menopausal. In gentlemen, you're over age 65 or 70. Secondly, is what your mom and dad had. If they had osteoporosis or they had hip fractures, that is a risk factor for you for primary osteoporosis. There is also secondary osteoporosis that can be due to a medical condition or a drug you're taking. Some of the medical conditions are diabetes, COPD, hypothyroidism, hyperparathyroidism, lupus, liver disease, rheumatoid arthritis, or if you've had a stroke. Those are medical conditions that can cause osteoporosis and cause an osteoporotic fracture. Some of the drugs, if you have epilepsy, if you're on an antidepressant, if you ladies have breast cancer and are on an aromatase inhibitor, or you gentlemen have prostate cancer and you're on an androgen drug, or if you're on steroids of any sort, or any cancer drugs, these drugs have a bad effect on your bone. Now, what should be done when you go to your doctors if you're a senior? They should evaluate your risks for osteoporosis and what your risks are for fracture. That's what we do in our practice. Now, how do we do that? They should take your medical history and find out, do you have a medical problem that might be causing osteoporosis? 2, what drugs are you on? 3, have you had any falls? Because 90% of hip fractures are due to a fall. And 5, how is your balance? Then they should examine you. They should check your back and I'm going to show a slide to see if you ladies or gentlemen have a dowager's hump. That's that back behind your neck. They are old vertebral fractures. They should check if you have back pain, and you should always be measured with a wall stadiometer. That's what we have in our office, and weigh you. Why? If a woman loses 1.5 inches in her height since age 18, or a man loses 2 inches since he's 18, you may have a silent vertebral fracture. Then what they should do for you is, if you ladies are 65 or older, you are entitled by Medicare to a bone density or a DEXA scan. If you're menopausal and 50 to 65 ladies, and you have risk factors for osteoporosis, medical problems, or drugs you're taking, you're entitled to a bone density. If you're a gentleman, you're entitled at age 70 to a bone density. And if you're 50 or older and you have medical problems, or you're on a drug that causes osteoporosis, you're entitled to a DEXA scan. Here's a picture of a DEXA scan. We measure your lumbar spine and your hip. And there's really very little radiation. Here's the tech with no screen between her and you. And if you've lost height or have back pain or a dowager's hump, we do a vertebral fracture assessment. We look at all your vertebrae and we measure them to see if you have a silent fracture. And we get what a DEXA scan is measuring: an area of bone, how much mineral divided by the area, and you get a T-score. They compare your bone density to a white female who's 20 to 30 years of age, who has a normal bone density, and we get a T-score. If your T-score is -1 to +1, it's normal. If it's -1 to -2.5, you have osteopenia. And if it's -2.5 or less, you have osteoporosis. If you have osteopenia, T-score between -1 to -2.5, we do a FRAC score. We do a calculation as what your 10-year fracture risk is for a hip fracture or a major osteoporotic fracture. And it's a computer study that your doctor should be doing right in his office. And there are 11 risk factors: age, sex, race, BMI, personal history of a fragility fracture, if mom or dad had a hip fracture, if you're a smoker, if you're on steroids, did you have rheumatoid arthritis, if you drink more than 3 units a day of alcohol, and we put down your femoral neck, your hip bone mineral density. And then we click a button and we get a number. If your 10-year hip fracture risk is 3% or higher, we work you up for secondary causes of osteoporosis and we treat you. If your 10-year fracture risk for a major osteoporotic fracture is 20% or more, we work you up and we treat you. Now, the problem with FRAC scores, it can underestimate. It doesn't say how much you drink, how much you smoke, how many fractures you had, whether you have diabetes or not. It is not written in stone. It's just a guide for we doctors who treat people with osteoporosis. Now, who should we treat? Who should we treat? The National Osteoporosis Foundation tells us any postmenopausal woman or any man who's 50 or older who's ever had a vertebral fracture or a hip fracture. And when we talk about fractures, we're not talking about fractures when you get hit by a car. An osteoporotic fracture is a fracture that occurs when you're standing and you fall and break a bone. We also treat people who have low osteopenia and their 10-year probability of a hip fracture is 3% or higher, or the 10-year probability of any major osteoporotic fracture is 20% or more. No one should ever be treated, and I see this a lot with some physicians, without working you up for secondary causes, because if you're on a medication that causes osteoporosis, we would try to change that medication or adjust the medication. If you have a medical problem that's causing your osteoporosis, we try to treat that first before we treat the osteoporosis, because all these drugs have side effects. You'll have to remember this, ladies that are out there. 50% of you postmenopausal women who are 50 or older will sustain a fracture, an osteoporotic fracture in your lifetime. And you gentlemen who are 50 or older, 25% of you will sustain a fracture. The problem with hip fractures in women is 25% of you, if you get a hip fracture, will die the first year. 25% of you will be sent to a nursing home, and 50% will walk with a walker. And last year, more women died of osteoporotic hip fractures than breast cancer. If a man gets a hip fracture, 40% will die the first year, because men, when they get hip fractures, either smoke, drink, or have many medical conditions such as hypertension, COPD, or diabetes. Now, what is the treatment of osteoporosis? Well, the treatment goal is one, stop bone loss, strengthen your bones, and prevent fractures. There are two types of treatment: non-pharmacological, which we're going to discuss first, and then pharmacological, which we'll discuss later on. The non-pharmacological would be calcium, vitamin D, physical exercise, and a fall prevention program. We do that both for men and women who are undergoing treatment for osteoporosis or for a high FRAX score. It's the same in men: calcium, vitamin D, exercise, and a fall prevention if you have osteoporosis. Now, how much calcium and vitamin D should you take? We recommend calcium, vitamin D, eat a balanced diet. The best diet is the Mediterranean diet, no smoking. And how much calcium should you take? If you're a senior, we recommend 1,200 milligrams of calcium for men and women who are seniors. Now, our American diet gives us 600 milligrams of calcium. If you have 8 ounces of milk a day, that's 300 milligrams more. A yogurt is 300 milligrams. 3 ounces of cheese is 300 milligrams. So I have a yogurt at bedtime, I have milk with lunch, and I have cheese with lunch. I don't take calcium pills. The only people that should be taking calcium pills are people who are lactose intolerant. Why? Because calcium pills cause gas, constipation, and kidney stones. And the largest randomized controlled trial, the Women's Healthcare Initiative, show that. But some ladies and gentlemen are lactose intolerant, and those people should take a calcium supplement. The ones that we recommend are calcium carbonate, 500 to 600 milligrams a day, taken at separate meals. Your stomach can only absorb 500 milligrams of calcium. So you would take it at separate meals. But to absorb calcium, you need vitamin D. Unfortunately, there are very few foods that are high in vitamin D. We recommend, if you're a senior, to absorb vitamin D, you need the D. If you don't take D, you only absorb 10% of your calcium. And we recommend that you take probably anywhere from 800 to 1,000 of vitamin D3, providing that your vitamin D level is normal. And that should be checked on your annual examination when your doctor checks your cholesterol, blood sugar, thyroid, etc. Now, the exercises that we recommend that you do at least 150 minutes of exercises to 300 minutes of exercise a week. Try to go for a walk every day. I know it's cold in here in New York. Bundle up, wear earmuffs, wear a hat, wear sunglasses, go for a walk, and don't just exercise once a day. Keep moving if you're a senior. Also, do muscle strength training with light weights, 20 minutes, 3 days a week, never on separate, a separate day, should be every other day, 3 days a week for 20 minutes. And try to do flexibility or stretching. All libraries allow and train people in Tai Chi and yoga. That's excellent for balance. If you have osteoporosis, we recommend a fall prevention program. Fall prevention program was doing balance exercising. You're entitled with Medicare to go to a physical therapy place, and they would teach you balance. You should your doctor should adjust the drugs. If you get dizzy with the drugs, you should have your eyes checked. When I was a child, we had night lights. You should keep a night light in your bedroom, in your hallway, and in your bathroom. Never wear slippers with leather soles. You're going to slip if you go down a flight of stairs. You'll fall and break a bone. Wear rubber sole shoes. Now, how about the medications? And I hope some of you that are on medications ask questions when I finish this talk, because all the medications have side effects. Nobody, I don't know how to keep stressing this. I stress it to the doctors, but it doesn't seem to work. Nobody should be on a medication unless you're worked up for secondary causes of osteoporosis. And there are several types of medication. The two main types are the drugs that stop bone loss. They kill the cells that make those micropits. Those cells are called the osteoclasts. And those drugs are the bisphosphonates, Fosamax, Actonel, Boniva or IV Reclass, and Prolia. The other type drugs build brand new bone. They connect the cross struts that are broken. Those drugs are called the anabolic drugs. Those are a daily injection, a tiny little needle, a diabetic needle that you give yourself every day for 18 months to 2 years that actually builds brand new bone. Now, what are some of the side effects of these drugs? There is no side effect of these drugs that causes death in the bisphosphonates, the anabolics, or Prolia, but a hip fracture and multiple vertebral fractures not only cause morbidity, but can cause death. So I would say the drugs are very safe to take if you need them. The side effect to the bisphosphonates, the ones that you take by mouth, Fosamax, Actonel, Boniva, the side effects to that are gastrointestinal, upset stomach or esophagitis, joint pain, muscle pain, bone pain. The side effect of IV Reclass, the infusion we give you, the bisphosphonate, the side effect for that the first time is a flu-like syndrome that can last 2 or 3 days. The side effect of Prolia is a rash that can occur over a period of 3 months that goes away. The side effect of the daily injections is dizziness, so we tell you to take those drugs at bedtime. I have to take a sip of water. I'm losing my voice. How they work. Fosamax, Actonel, Bonura IV reclass, kill the cells that say osteoclast on the lower left. Those are the ones that make the pit. Prolia stops the birth of those cells. What the anabolic drugs do, the ones that you take every day, they stimulate the osteoblasts to grow, proliferate, and connect these struts. After 1 or 2 years after you're on these medications, we recommend a bone density. We recommend a bone density. It should be done in the same place that you had the first one. Otherwise, we can't compare them. That's so important. It's so important. Now, you have to remember, if you have osteoporosis and you're on drugs, osteoporosis is a chronic disease. It requires long-term follow-up and monitoring, and the medications that we give you are individualized. If you have chronic kidney disease, you can't take a bisphosphonate or IV reclass because it's secreted through your kidneys. In a case like that, we would use Prolia, which is not secreted by your kidneys. So the therapy is individualized. Now, what about a drug holiday? When you're on Fosamax or Actonel or Bonura, after 5 years on that medication, your bones don't get any stronger. And if we do a DEXA scan on you and you no longer have a T-score in the osteoporotic range, we may give you a drug holiday and follow you to see if you need the drug again. If you're on IV reclass, if you no longer have a T-score in the osteoporotic range, we may give you a drug holiday. There's no drug holiday with Prolia. We can use it indefinitely. And there's no drug holiday on the daily injections that build brand new bone. Now, if you still have osteoporosis and you're on Fosamax or Actonel or Bonura, we might continue for another 5 years, or we may switch you to Prolia. If you are on IV reclass and still have a T-score in the osteoporotic range, we might continue for 6 years with the IV reclass, or we might switch you to Prolia. There is no drug holiday with Prolia. And how we follow you is we do a blood test on you, because we can't do a DEXA on you every year. Your insurance won't pay for it. And we check in your bone for substances that are released by the cells that break down your bone. They're called bone turnover markers. My treatment goal, and what your doctor who treats you, treatment goal should be a T-score in your hip between minus 1.5 and minus 2. If we can get at that level, we know we can prevent fractures in you gentlemen and in you ladies. A lot of people are going to say, what about osteonecrosis of the jaw? I'm afraid to take medication for that. Number one, it's very, very, very rare. And what it is I get a tooth pull and it doesn't heal for 2 months. And in 2006, there was an article in our osteoporotic journals in which they found 368 cases. 95% of them were on IV reclass, a drug we use for osteoporosis, or pamidronate. 85% of these people had multiple myeloma or metastasis, and they used quadruple the dose that we would use for osteoporosis, and only 4% had osteoporosis, and 60% had a dental extraction. But what the American Dental Association says, and what we do in our practice, is before you go on any drugs, you should have a dental exam. I go 4 times a year. I get my teeth cleaned, so it would be safe for me to take it. And the expert panel, and if you go to the American Dental Association, said all patients should receive routine dental exams, and routine dental treatment should not be postponed because you're on a medication. And what we recommend, if you're on a medication and they have to pull your tooth or do a implant, they should give you an antibiotic mouthwash. That's my lecture. The takeaway points are the following. If you're a senior man or a senior lady, you're entitled to a DEXA scan. 1. 2, your doctors on your annual exam not only should measure and weigh you, but they should evaluate your risk factors for osteoporosis and fractures. 3, if you have osteoporosis, and you've been worked up, no medications unless you're worked up, the medications are safe to take. If you have osteoporosis also, you should not only take calcium, vitamin D, and medication, but you're entitled to a fall prevention program. And that's the last thing I have to say. So I hope you enjoyed my talk and you learned something. And if you have any questions, we're open for questions.
Thank you, Dr. Bonura. So I'm going to be reading the questions from the chat, and if anyone has any other questions, they can put it in there, or they can unmute themselves and let you know. Let's see. Ian had asked, what were bone density tests for men over 70? I think he wanted the name of what that was called.
I'm sorry, what?
He said,
What
were the bone density tests for men over 70?
Yeah, any man can go for a DEXA scan, a bone mineral density, if he's 70 or older. If he's 50 or older, and he has risk factors for osteoporosis, say his mother had a hip fracture or dad, he can have a DEXA scan. And there's very little radiation.
Okay.
And if a man has lost 2 inches in height since age 18 or 20, he should also get a VFA, a vertebral fracture assessment. There's very little radiation. For example, a VFA is 5. The dose of radiation is 5. With a back X-ray, it's like 300 or 400.
Let's see. We had Christine ask any information on Evenity, which is
Okay.
I don't know how to say it.
You see me smiling. Do
Yeah.
any of you get People magazine? The reason why I ask, I think Evenity is an excellent drug, but there's a black box warning. One of their studies showed an increase of cardiovascular disease, heart attack, stroke, and cardiovascular death. And when I show that to patients, they say, I'm not taking that because the 2 drugs that we use, Timlos and in the past Forteo, those are drugs that work like Affinity, don't have that black box warning. So Evenity, their first study was great. They compared it to a sugar injection. There was no cardiovascular events, but when they compared it to Fosamax, they showed an increase of cardiovascular disease, stroke, heart attack, and cardiovascular death. So any woman that I show Evenity to, they don't want to take.
Okay, great. Thank you. Let's
Make
see.
sure, excuse me for interrupting, that if your doctor recommends it, you ask them to go over the black box warning.
Great. Let's see. Okay, so Kathy, thank you for that. Kathy said, any info on Evista?
Evista is an excellent drug. I was a speaker for Evista. Evista is the perfect drug if you're postmenopausal in your 60s. You have osteoporosis of your spine, you're not at risk for a hip fracture, and you have risk factors for breast cancer. Studies have shown if you're on Evista for 3 years, it reduces your risk of breast cancer by 76%. So I think it's an excellent drug, but it doesn't affect or reduce your risk of a hip fracture. And if you take it too close to menopause, you can get hot flashes.
Okay. Let's see. Bonnie asked, does taking collagen help at all?
I don't know, a lot of women take it for their face. It has no effect on osteoporosis. What is so important for us seniors is a balanced diet. I'm Italian. We eat the Mediterranean diet, fruits, vegetables, nuts, etc. You can Google that. I drink milk, I eat yogurt, I eat cheese, low fat. I try to exercise almost every day. That's the most important thing if you want to live life and be healthy, a long life and live healthy. And keep moving. At our last Menopausal Society meeting, I'm director of menopausal health at a hospital in Atlanta. They said it shouldn't just be exercise in the morning. Keep moving, you seniors. Go for a walk morning, afternoon, and evening. Keep moving.
Okay.
Anyone out there on Prolia? Anyone have any questions on Prolia? Or
Yeah,
on the bone building drugs?
there is a question. I'll skip ahead to that one. Sharon said, I have osteoporosis in my hip and I'm on Prolia. I do Pilates on a reformer. Is there anything I should know about doing Pilates?
I'm sorry, she doesn't do Pilates or does
She
Pilates?
does. I guess she
Well,
was
what
wondering
I
if
do
there's.
is Pilates is excellent for stretching, etc. But the exercise for osteoporosis is carrying your own weight, walking. I spin 3 times a week. I lift weights, which stimulates my bones, but I don't walk enough. In the past, I had horses. I would rise horses, and my horses would be caring for me. The exercise for we seniors for osteoporosis is walking, carrying our weight against gravity. So Pilates is excellent, but go for a walk a few times a day.
Okay, so Ross asked, why does hip fracture and osteoporosis cause death?
Well, if you get a hip fracture, what can occur is 1, it releases inflammation. 2, you're in bed, you can get pneumonia, you can get a cardiovascular problem, you can develop any cardiac arrhythmia, you can get an infection, or you can get a bleeding. The major cause would be pneumonia or a clot in your leg that goes to your lungs and kills you. Yeah. In men, it's higher because senior men have more medical problems in their 80s. Hip fractures don't occur in 50, 60, or 7-year-olds. They occur when we become 80 years old.
Okay, next question. Karen said, if there is medication that actually builds bone, why not take that rather than other medications?
Okay, I didn't say it. That's a great question. What we do and what your doctor should do is when they evaluate you, are you at high risk for a fracture or very high risk for a fracture? The people that we use, the bone building drugs, are at very high risk for fracture. What does that mean? They have osteoporosis and had a fracture before, or their T-score is -3 or more, or their FRAC score, they have osteopenia, and their FRAC score of a hip fracture in 10 years is 4.5% or more, or their total osteoporotic fracture risk factor is 30% or more. That person is not at high risk. They're at very high risk for a fracture. So those are the women and men we would use a bone building drug.
Thank you. Next question from Martha. Does osteoporosis make osteoarthritis more likely?
No. Osteoarthritis is a condition depending on what you ladies and gentlemen did when you were younger. We see it. My wife was an athlete. She has osteoarthritis. What it means is the cartilage between your joint wore away from all the activities that you did as a young person.
Great, thank you. Paula asked, will bone be built via the non-pharma approach of diet, calcium, and vitamin D supplementation?
Okay, that's another thing I didn't say. No clinical study shows that If I have osteoporosis or I'm a senior, calcium, vitamin D, exercise daily will do anything to the osteoporosis. That's why I said in the beginning, I can prevent it if I go to grammar schools or middle schools and tell kids, milk, yogurt, exercise, don't smoke, don't drink. We can prevent it in young people so they can arrive at their peak bone mass. But once you have osteoporosis, no diet, no supplement can cure your osteoporosis. You need medication.
Okay, good to know. Thank you. So we have another question from Henry. You have a lot of questions, by the way. I am aware that I'm shrinking. How can I stop this from occurring? Is there a way to prevent it? Or
I'm sorry, what did you say?
he said he's aware that he is shrinking. How can he stop that from occurring? Or is there a
Well,
way
the
to prevent
first thing
that?
is I lost 1 inch since I'm 18. I don't have a vertebral fracture. The gentleman should be measured by a wall stadiometer. And if he's lost 2 inches in his back, his doctor should order a vertebral fracture assessment. I showed you a picture of that. There's very little radiation. And then we calculate whether he has a asymptomatic fracture of the back. And 75% of them are asymptomatic. You shrunk for no reason. So if he has, we call them morphometic fracture. If he has a morphometic fracture, and even if his bone density is normal, he's got osteoporosis. He needs to be worked up and treated. Otherwise, he's going to shrink even more.
Thank you. Go ahead.
Any other question?
Oh yeah, there's at least 12 more. Let's see. From Grace Anna, is there a risk of osteosarcoma with the use of Forteo as is with animals?
Okay. Up to 2022, there's been no cases in humans of osteosarcoma with either Tymlos or with Forteo. In rats at higher doses, there was an incidence of osteosarcoma, but we still, if you've had radiation to your chest as a young child because you had lymphoma or you had breast cancer and radiation to your breast, we don't use it. But there is no studies in humans that shows that Tymlos or Forteo causes osteosarcoma.
Let's see. So Bonnie asked, she saw a study through PubMed recently saying that 10 prunes a day change the microbiome and increase biodensity. Do you have any
I'm
thoughts
sorry,
on that?
what? I didn't get that.
Sorry, Bonnie said that through PubMed recently published a study saying that 10 prunes a day changed the microbiome and increased bone density. Do you have any thoughts on that?
When we look at studies, there are two kinds of studies. One study is an observational study. Another study is professional opinion. The only studies that are clinically valuable are randomized controlled studies, which means we take 1,000 women. We don't know who got the medication. We don't know who got the sugar medication, and we follow them. Those are the only studies that are important to physicians, randomized controlled studies. Some of them are double-blinded, which means not only does the patient know, but the doctor doesn't know which drug and who's getting the sugar pill. There is no clinical studies that show that prunes work on your bones. I take prunes every day for a different reason, for the GI tract, but it has no effect on your bones.
Okay. Debbie asked, can daily Synthroid and 6 months of pantoprazole contribute to bone loss?
Well, if you have getting too much thyroid medication, that can affect your bone loss. And what was the other drug? For blood pressure?
Synthroid or
Synthroid, if
pantoprazole.
they're getting too much. The second drug was what?
Pantoprazole.
But some studies show that proton pump inhibitors for gastric acidities can decrease your calcium absorption. I would just, it's not really a risk factor that we would worry about.
Okay. Susan asked, is vitamin K also good for bones?
There's no study that shows that vitamin K has any effect on your bone density.
Okay. Someone asked, is the loss of lordosis related to osteoporosis?
Lordosis of a spine has no effect.
Okay. Zoe asked, how long should you be on the IV before a drug break?
The IV reclass, it's an infusion that if you had osteoporosis once a year for 3 years, and then we repeat your bone density.
Okay.
If you're no longer T-score in the osteoporotic range, we can give you a drug holiday for 1 to 2 years. If you're still in the osteoporotic range, we may give you several more doses or switch you to something like Prolia.
Should someone who develops kidney stones be taking reclassed?
If you have kidney stones they should check your kidney function. If you have an alteration of your kidney function and we do a test on you, there's a number. If it's less than 35, Fosamax, Actonel, Boniva, IV reclass are excreted through the kidney. And in those cases, we'd use something else like Prolia, which is not excreted through the kidney.
There's a question. I take Residronate. Is that a good medication, or is there something better? Residronate.
What does she take? What?
You wrote Residronate, RESID.
Residronate is Actonel. Actonel is an excellent medication to take, but I stopped using oral medications, and the reason for it, and I was a speaker for Fosamax and Actonel, I don't use them because the adherence is poor. Secondly, you have to take it on an empty stomach with 8 ounces of water. Thirdly, you can't lie down for a half an hour to an hour. So I prefer to use injectables because if I give it to you, I know you got it.
Okay. Marie asked, if a person has an insect vector disease such as Lyme, Bartonella, etc., would this change the treatment protocol for osteoporosis?
Has no effect on that.
Okay. How does I'm going to combine 2 questions. How does swimming affect bone health, and is biking helpful?
I just explained. I had a horse, and I spin. I lost bone because I'm not carrying my own weight. My bicycle and my horse carried my weight.
Right. Okay.
So spinning is good for your heart. I spin in the studio and I have a Peloton. It's great for your heart and for your muscles. I lift weight 3 times a week, but it's not an exercise for osteoporosis. The exercise is weight bearing. Go for a walk 3 times a day and lift weights, light weights 3 times a week, 20 minutes on alternate days, or use bands.
To follow up on that, someone said, you mentioned walking was helpful, but since my issue is primarily in my back as opposed to the hip, I heard that walking doesn't really strengthen bone in the back. Is there a better exercise for osteoporosis in the back, or is it still walking?
I would say walking, but if she has back problems, she should see a physical therapist and work out an exercise program for her.
Okay.
And also, if she's a senior lady with back pain, and when she goes for a bone density, they should do a VFA to make sure her back pain is not due to a vertebral fracture.
Let's see. I don't know if we're going to be able to get to all these questions. There's at least 20 more. I'm going to try.
Well, let me just say one thing to the audience. If anyone has any questions, we do telemedicine We do consults, not only for osteoporosis, but we do consults for any menopausal or gynecological problem. And my office is here at St. Catherine's Medical Office Building. And you can, my telephone number, just go to my webpage, frankbonuramd.com.
Okay, thank you. Yeah, I don't think we have time, unfortunately, to get to all these questions. But I hope we answered most of them. As Dr. Bonura said, feel free to visit his website. He's, a practicing physician. You can always schedule a consult, etc., or visit your doctor to ask how to go about this. I hope everyone enjoyed this program. Again, it is being recorded, so we will make a recording available to everyone. We will be sending it out in an email. We hope everyone enjoyed it, and thank you so much, Dr. Bonura. We really appreciate you coming.
You're very
this morning.
welcome. Enjoy the day. Have a wonderful lunch. Go for a walk. It's beautiful.
Thank you.